I told mothers, I told dentists, I wanted to see them at this age. I treated them. And everybody says, well, Ricketts, one of these days you'll be sorry. One of these days you're going to have them all to strap up and do it all over again. So I met him 2 or 3 years later. I said, I'm waiting. I'm still waiting. Boys, I'm still waiting for that day you said I'd be sorry. That day hasn't come. If you don't want to treat them, you send them to me, would you please? Because the day never came. Now, well, there were cases we made mistakes on. Some children that we didn't recognize a respiratory obstruction. Some patients didn't get the amount of growth that we would expect a child to get. But rarely would we miss on the class 3 side. So the ones we would miss would be the ones that we failed to recognize some inhibitory growth factor. Notice that he's got upper cuspids that are completely blocked out. And in the lower arch, the lower canines are canted off labially. Okay. Now there was a story here to this case. This child's father was in the Rotary Club with me. And he asked me if I would please see his son. Because the mother had taken him to another orthodontist. Orthodontist wanted to take 4 teeth out. And that his mouth was flat, his wife's mouth was flat. And he said, since he's already flat, it doesn't seem to me that it would be a good idea to do. And so I said, well, I can do it if we take the 3rd molars out of her. If you notice there, the molars are laying right on their side. Here's the 3rd molar, here's the 2nd molar, here's the 1st molar. The canines out here, and we've got each space to take advantage of. So I thought I could handle the lower. But the upper 3rd molar is so small, it's hardly any bigger than the bicuspid. So if I take out 4 teeth and try to use that, I haven't saved anything. We want to set this lower arch back into an anchor position so that we can bring the upper molar back into a class 1. So it will probably look worse. So we extracted all 4 3rd molars and put him on a ligated utility on the lower in order to put this tooth back into an anchored position. To start a tip back and the distalization of this tooth to open up space for the 2nd premolar and the canine. Now here it's plainly evident that the lower 2nd molar is moving distally. Look at the new bone on the mesial. You see it there? Look how it's filling the space for the crypt of that 3rd molar that was taken out. On both sides. And you see the new bone forming here too. And you can also see new bone on the mesial side of the 1st premolar. 2nd premolar. So you knew this tooth is moving rapidly in that direction. Now you can see new bone on the distal of the upper lateral. So you have an idea those are moving forward. This is the first stage. Look how much I've straightened these utilities out. These were opening utilities with no brackets, just the lower incisors. Due to the deep bite, we just ligated the utility onto the teeth. 4 brackets here. And 4 molar bands. Now we put him on buccal segments as soon as the upper canines come down. These lower 2nd molars have continued to move distally. Segmented mechanics to move this back. Just keep bumping the 2nd molar back. And here we are into the ideal arch phase. Here we were earlier when we had our loops in to do all of the rotations before we went into the ideal state. So opening utilities, then loops, loop sections, 4 of them. And then some sectional mechanics to get the upper buccal segment all the way back. At the time we retained it. we said that we wanted to make sure that we saw him when he was age 19. He wore a 4-to-4 retainer. And he comes back from college at age 19. No extraction. Does he look like he's protrusive? How could he be? Okay. Notice this tooth's in crossbite. The upper lateral. Okay. Now we can take advantage here of how much space. 2.8 millimeters a side. That's an average. So if we can move these back into an anchor position, ligate these down because of the, so you couldn't put brackets on here. There's no place to put brackets with this deep bite. So we're going to put bands on his first molars, come around here, and ligate a utility. We're going to go ahead and bracket these teeth and put a utility up here. The objective is to make space for canine. Here is original. You notice that the lower incisor is -4. You finished at +3. He's 45, 85, 62. Here he is at 14. Before we finished it. Here's now the total changes from when he started at 12 until 15. You can see we've moved the molar back. You can see here the upper molar moved backward. And 1, 2, 3, 4, 8 millimeters to get room for 15 millimeters of arch length. Where did it come from? It came from lateral. Now here he is at 19. And let's look at this profile. He's 118 interincisal length. There's his occlusion. He's still wearing a 4-to-4 there. Notice this nice occlusion. He's got all 4 cuspids in. We'll probably leave it in a couple more years. Problem is they forget that this is even in there. But it's not going to hurt as long as it's well cemented and well fitted. So I prefer to have these bands on. We can bond them, but they're a little bit harder to maintain bonded. Now here's the actual compared to the computer prediction. Notice the features of the therapeutic ideal. This distalization here, buccal position here, labial position here. That's a classic Ricketts therapeutic ideal with a 4-to-4 retainer. That's made direct. We make these directly in the mouth. I've had them in the mouth in 2.5 minutes. And I prefer to do them the day the bands come off. He's wearing an upper retainer at night only, just to stabilize a little bit. Look right here. A headgear widens the palate. See the widening of the palate here? This is all new. It's all new tissue. Okay. Here's this little girl. You saw her x-rays. Head back. The tight. SCM. Bad head posture. This is the one that had the palate 11 degrees. Beginning of a deviation in the septum. We put her on a quad helix to start widening and to break up the thumb habit. Then we put her on a headgear. You see the new bone here. Here she was, now here she is. Definitely a change in the palate. Here she was, now here she is. Definitely a change in the nasal cavity. Septum deviated, now it's straightening out. And here she is, just about the time that we took the quad helix out. Notice that there's not enough space for the lower lateral. Now we put her on the headgear.
ヘッドギア。
Now look at the width increase that we
幅
got.
が広くなりました。
And now notice that the lower ladder
科学2番が出ています。
has excessive space.
余裕があります。
Here now that this tooth was beginning to strip due to lip pressure to get her mouth shut. Now look at the tissue on these lower
で、
incisors.
下腹
Now we took her all the way back to a class 1. There's the change in the palate.
口外骨これほど変わってきます。
Look how little we moved the teeth.
歯牙の動きはごくわずかです。
The lower molar intruded and the lower incisor came forward because we changed the environment of the lip. Now we had to go in and finish her up. She started out open bite. We ended up intruding both the upper and lower incisor because the palate had come down.
口外が下がってきたから。
So we're here intruding the lower and front teeth. And look at the beautifully developed class 1 now. Now anybody should be able to treat this.
誰でもこのように。
We had her on a full hookup and the midline's still off. But I left this in to show again this therapeutic ideal and what you're going to get with the 4D.
4D を使うとこういうふうになる。
Now this tooth is a little oversized, see?
ちょっとこの歯が。
So these two teeth here looks to me like maybe they could have something done to them. Here she is just before in the semi-ideal stage. Notice the nice width in the stretcher. And here she is now retained. I think this is the day we cleaned her up after the lines was removed. Now she has this little midline problem. So I stripped here.
ここをストリッピングしました。
Stripped here.
ここも同じにしました。
Stripped on this
こ
side
こも
of this
そ
tooth
うで
here.
す。こちらの歯だけのストリ
Now
ッピングしま
stripped
した。
here.
今度ここを削って、
Here.
ここもストリッピングしました。
So that these teeth would shift this way.
科学は少し
And
の方
these teeth would shift that way. Now let's see what happened. Notice we got contact 14,
14番のコンタクトがここです。
both sides.
両側です。あります。
Notice we got contact 6,
こちら6番のコンタクトです。
both sides.
両側も同じです。
Here she is now, years later.
もうですね。
Notice the midlines are now on.
成虫は
You like that occlusion?
いかが
She's cute.
とても可愛い。
Here it is now. Here she is at 15.
7歳の時に始まって
We
15
have her
歳
now
の
at
時で
18. Okay, let's look at this case then. Here's a child that had fallen down, hit his deciduous tooth, jammed his upper central, jammed both of them at
両
one
が
time.
表です。
So he has what we call Turner's hypoplasia. He was seen by an orthodontist at age 6.
6歳の時に矯正のところに
He
行って、
told him it was too early to treat it.
6歳の
So here's the models he took. Here's a head film he took.
6歳の時のヘッドフィルム。
2 years later, he came to us.
2年経ちました。こうなりました。
So here he is at 6.
6歳の時にこれ
Here
で、
he is at 8.
こちらが8歳です。
His protrusion is about the same, but his depth of his bite has gotten worse. See? So here he is now at 8.
8歳になっています。
And you see the amount of strain that he has in getting his mouth shut.
え
He's got a lateral abscess here.
口外側に脳胞が
Infection
が
of
で
the
きています。
deciduous tooth.
乳歯に感染があります。
His mouth is dirty. This upper arch is extremely narrow.
で、上顎アーチは随分狭くなっています。
And he's chipped the central.
セッターが少し折れています。破裂していま
And
す。
he's got this Turner's hypoplasia on both of these.
両
I don't know, but if I'd seen him at age 5 or 4 and a half,
5歳あったと思いま
I
す。
might have been able to save these accidents. I don't know. But here we're faced with this at age 8. Still class 2.
2級のままです。
And if this is left, of course, this will go right up into his palate. Now we put a headgear on him
ヘッドギアを使うことになりま
at
す。
this stage.
ここ
Look
で
at the narrowness through the side.
アーチが大変狭くなっています。
No quad helix. Nothing on the lower whatsoever.
科学には何も使っていません。
And we take them all the way back, and then we put a full appliance on.
全部につくようになります。
Now look at the width through this arch.
アーチの幅が広がってきました。
And all we did was just drop on our appliance and detail. We didn't widen, didn't expand,
あとはプランさん
just finished. Notice he's overtreated.
オーバートリートメントになっています。
So this is just as we took his appliances off.
だから
Here's his model. We have him treated just about the time other people would start it. So we trimmed these teeth down that had been fractured.
で、破切したところは少しトリミングしました。
And this is when we put our retainers on.
リテーナー
Notice now how he's settled in. Sometimes with these modeling here, you can just take a little bit of that and put a little composite right over that and bake it.
ここ白くなっているところ
And
が
then
あ
you
り
get
ま
rid
すが、
of those spots on
削
his
っ
teeth.
てそしてコンポジットを入れてもきれいになります。
Notice again these classic features.
典型的な特徴が見られます。
The tucked in canines.
犬歯が少し
The
レッスンの方
rotation
に
of
入
the
ってい
upper
ます。
molars.
上
Rotation
顎
of the
大
lower
臼
molars.
下顎大臼歯
Here he is after retainers have been
リ
removed.
テーナーを外した後の状態。
Look at the width now that he's got.
幅がこんなに広くなっています。
Remember what he started with?
最初は随分狭かった。
Now I don't know why he had all this decay. I don't know whether he was hungry for sweets or whether it was a hungry dentist.
だから患者が、
Whatever it was all at once.
いずれ
So his teeth turned dark.
歯がまた黒くなってきました。
But here, now at 21 years of age,
21歳になっています。
look at the growth pattern he had.
この
That wasn't an activator.
これは
That was in there for him from the beginning.
最初からこうなるよ
From
うになっ
8
て
to
いたわけです。
21.
8歳から21歳まで
Look
の
at
比較です。
position 1 here.
やってみるとわかります。
Look at the mandible on this guy.
このところも科学すごいです。
Who's that look like? One of the guys who used to play a western. What was his name? Who was it? Matt Dillon. If I'd have seen this patient at a younger age, I probably would have treated it differently than I treated it here. In that particular case, it's a lot of reduction without taking teeth out.
歯が抜歯しないでやるということはなかなか大変でしたが、
I don't think I could move the lower incisor back 7, 8 millimeters without
無理だ
extraction.
と思います。抜歯をしないで
So I
7、8
think
ミリ
that
も
would be a
後ろにあるのは無理だと思い
difficult
ます。
thing to achieve in this patient without taking teeth out. So we did extract this patient with teeth. I took 4 bicuspid.
はい、4本小臼歯を抜歯しました。
Now let's go through the treatment regime. Whoever worked this case up, the computer got 11 millimeters
こ
of
の
convexity in this case.
コンベクシティが
In the beginning, he was still had one deciduous tooth remaining.
開始時でありますが、乳歯がまだ
And
残って
two
いま
up
す。
here.
上顎にも2本残っていま
So
す。
I think if I would have had a chance to get the orthopedic phase in him, we probably would have treated him differently. Here's the result.
これが終わった時。
And if you notice, okay, go ahead and look at that. Here's his actual tracing
これは実際のトレースのことになり
at
ま
the age of 15.
す。15歳です。
And fortunately, I don't have an x-ray after 15 anymore. And you can see a significant amount of reduction of the convection. And we got his lips back inside the E-plane. Now in class 2 extraction, it's a little bit more of an anchorage problem in the lower arch. Looking here is a problem with anchorage.
これでご覧いただきますように。
You can see the amount of retraction in the lower incisors that we gained.
化学精子のリトラクションの量をご覧いただきたいと思います。
And even with the class 2, you see,
こう2
we
級で
only lost 1 millimeter of anchorage in the lower arch.
ね、
I don't know whether you know it or not, but that's significant. You close the space up for extraction in the lower arch, plus using the mandibular teeth as an anchor
で化
to
学に
retract the upper teeth.
化学を抜歯して、そしてその抜歯管を埋め
Only
てい
1
く。
millimeter.
引っ張
I don't think I could do that with standard edgewise technique. Now I forget whether we had any extra oral traction on him or not, but it certainly looks as though we reduced point A. This is back when we were doing a VTO instead of a VTG. I very seldom do a short-range forecast, except in those patients in which a short range is equal to a long range with only 2 years left. And this is what it called for. We could accept the lower incisor with just a little intrusion. It was very interesting here, no headgear. All I did here was to put in a wire, a utility first, and intruded the 2 upper centrals. Then we picked up the 2 laterals, and with a 16 square wire. It's not even a utility. It's be interesting now to follow. Here it was in 1962, superimposed over the palate. Now we tipped the molar back. But look what we were able to do with this upper incisor. Just look at it. Now here we turned it loose then. The upper incisor just about stayed. From the palate it was 92 degrees, now it's 120. So we torqued this to 28 degrees. Now what I'm trying to do here is to show you possibility. Keep in mind no extra oral traction. And ultimately then, by full maturity in 73, which was 11 years later, we put on a full appliance, and here he is now 11 years after the start of treatment. Notice how near an end-to-end he is with this well-locked occlusion here. This is what I'm after in an occlusion. Remember, he was class 2. Notice contact 20, 14, contact 10, contact 6. So all of these now, you see, are really in a solid rock occlusion. Here he's at age 20. And you can see the relationship here. This is almost pulled in too much maybe, but we still didn't use extra oral traction. Very handsome man. He's an officer in the Coast Guard then. And here he is then, well up into his 20s. Showing you how this occlusion is maintained into that very shallow overbite. All right, let's have her here. This, I'll show her here and then see what he did. Yeah.
Okay.
We'll just go through this since we got the parasites. Here's one of these lips I'm talking about. This is a very tight lip, the metalis. Plus you can almost see this quadratus right here. You see the corner of the mouth pulled down. And the lower lip curled. Here's her mouth. This is a deciduous canine. And the permanent canine is down here and over here. The permanent canine is almost touching the canine of the opposite side. Here it is over here, almost against the canine here. So what we did, can you focus this?
There it is.
Okay, all right. Notice the crypt around here. That's an active blood supply, and so you don't want to clean that out. That's going to help you resorb the tissue away. So I did the surgery myself. Notice here's that tight lip, and we went in and relieved the quadratus here. And I took this down all the way to the bottom of the symphysis here, so I could get it loosened up. Then I took a bone burr here and made a channel, so that this tooth would have a track to run in. we put a utility on with a little cover here, advanced it on this side because the space, we had to create space here. So, and we moved these roots lingually. So now we had to get a hold of them. So I took a canine band and trimmed it so that it just covered this much of the tooth. And I just cemented it on as a facing. Now you know I couldn't be pulling on it very hard. Because there's no band around it and it's not bonded, it's just cemented onto the face. And of course it's got a bracket on it. So I put in a wire here and put in a thread ligation underneath the tissue. I made a cut in the tissue here and went in and sutured this back in place. And now it's got a bony channel to come through with an attachment on it. Now we took her all the way back here. Now we brought it all the way from here. And now started to bring it up. And of course I pulled it off. So we put in a retraction like a custom retractor to get the root back now. Now we got the root back. Now I've got excessive space, so I'm going to put this in to close the space. Now with the preoccupation with this, I failed to tell you that there was also an attraction in the upper canine. So we did the same thing here that we did in the last case. We just started tipping back from the molar and advancing. Now, after that then, we went in and put an intermaxillary traction. Once we got this up this far, there's a stop here. So we're activating this directly with an elastic from the back. Remember, she was a closed bite starter. So now we're in the ideal stage, going into over-treatment. Then we take the buccal segments off, as we commonly do, and correct our midlines. Do a little uprighting. And continue with the elastics. Make certain we close the spaces up from the back, from the front back, not the back forward. In other words, we take these arch wires out, take these bands off. So that's a partial debanding or debracketing, whichever way you want to look at it. We can use a transverse or class 2 or even class 3. These are our finishing arches. And these are our final torquing in the upper and lower teeth. Here we are in the attempt to over-treat. See, and here she is. This was her lip before, now here's her lip now. That same lip procedure I did here on her. But you can see now the result of this. It would be very difficult to say which one of these have been operated. Little scar right here. But here it is at the level where I operated it right here. Now all this is new growth. So the gingiva comes right along with it when you operate one that early. And here's again our occlusion. Here she is years later. I finally talked her into letting me go in and manicure here a little bit. Now I'll call your attention to the prominence of the lower first bicuspid, the tucking in of the canine, slight overlap of the lateral, and of course the prominence of the first bicuspids in the upper also. That's what makes a Ricketts smile. Alright, we'll look at another crowded case to give you some principles of expansion. Here's a little girl with this lingual tooth here. And look here. I took these models and showed it at a meeting one time. There were 72 men at the meeting. Everybody in the room would extract the case. Most of them would take out first bite. Some would remove second bite. A few would take out this lower incisor. The average lower incisor is all the way back here at 97. Look at it, way back here. There's that one tooth that was ahead. But the mean incisor would be way back up here. Alright, now what would you do? Well, we went in here with a utility arch. That was custom. So this was a second arch put down in here so as to hold the lip away from this tooth, which was already cleft. She had a crossbite here. So after having got this tooth down so we could jump it over, the bicuspid. Okay, now we got the crossbite jumped over. And we're still class 2 on her left side, her right side. So we have to go in now and put a section on here, like the ones I explained to you this morning. And what I didn't mention to you was the fact that we started out the upper with a headgear. And I want to call your attention to the fact that these 2 upper incisors are now straightened out with no orthodontic appliance other than just the headgear. Now we went in and jumped above the segment and put a little necktie on here. Just as a little elastic in order to overtreat the segment. Okay, here's the result. No extraction. No extraction. Notice the characteristics that I've been talking about. She's now a doctor. She's a physician. She's got a beautiful face. There's very little lip strain. This was compared to her forecast. Mandible was opened a little bit, and we didn't have to advance the incisor as much as we thought because the lip was so tight it worked the denture back. See it? Plus we used some extra traction. Now here she is at 35. This was clamped all the way down to here when we started. So we didn't do that. Might have done this because the roots were moved out a little bit too much with the retainer. We discussed doing some surgery on these teeth. She said it wasn't any worse. Forget it.
2級のオープン代表です。これは側棒ですが、この写真から見る限りでもメンタリスの緊張がこれは安静時でやはり腰を少し開いた状態にしているということとこの右側ですね、鼻腔のエクセンの特性が悪いので、